is a sexually transmitted infection, and you should use condoms for 6 weeks after you travel, even if you didn't have any symptoms. That's actually the CDC recommendation. But unfortunately, we don't have it in California. But you may get questions about Guillain-Barré in your boards because it's one of the complications. But there are many different viruses actually that can be associated with development of Guillain-Barré, including CMV, Epstein-Barr virus. What else Epstein-Barr virus causes? Mono, very good. HIV, hepatitis, Lyme's disease, Campylobacter jejuni. And this is, Campylobacter is associated with what else? You guys remember for your boards? Campylobacter? I'm sorry?
Pneumonia?
No.
Immunocompromised?
No, it's associated with bloody diarrhea, and it's associated with appendicitis-like syndrome, and especially in young people or children. They can actually present with lymphadenopathy, and then very often they end up going to the OR for no reason. And Zika virus. But anyway, the bottom line is that Guillain-Barré, it's an immune-mediated demyelinating polyneuropathy. So the easy way to remember is like the way you describe it. The patients have distal weakness, they have no reflexes, they can have an impaired sensation, and sometimes they can have an autonomic instability. That's why I mentioned that this person was tachycardic. It's a sign of autonomic instability. And sometimes the involvement can be not only distal, but it can progress to proximal, including some cranial nerve involvement. Most cases are triggered by infection, surgery, or sometimes with immunization. This is one of the rare complications of influenza. One of my clinic patients, he refuses to get it because he's been living for the last 20 years next to a person who actually developed this ominous complication, and she's been wheelchair bound ever since she got a flu shot. It's very rare. I've never heard of it. In fact, I do heavy education into immunizations. You guys should do the same because we know that that's the way to save lives. You guys know what the treatment is for Guillain-Barré? Actually, it's supportive care. We do. We admit these patients when they have like pretty progressive weakness. We admit them to the ICU, and we follow the forced vital capacities and the negative inspiratory force, which is measured by the little device that they have, and you are able to tell whether or not the patients are getting worse, whether or not you need to intubate them, because that's one of the reasons why these people die. They become hypercapnic, and you need to mechanically ventilate it, otherwise they're not gonna make it. So some of the treatments include IVIG. We cannot use IVIG in the advanced kidney disease, and also is relatively contraindicated in those patients suffering from IgA deficiency or CHF. But for the most part, the main treatment is plasmapheresis. Have you guys ever seen plasmapheresis? Have you rotated through a hospital yet? So it's like a dialysis type of procedure where they have a big machine, and the machine actually exchanges plasma, fresh frozen plasma. So it takes your blood, filters out the you know how you are able to centrifuge your blood and you're able to separate the components, the cells versus the plasma. So the machine does something similar, and it removes the plasma, the diseased plasma that has these circulating antibodies, and actually brings up the new fresh frozen plasma. The complications of plasmapheresis is that once you're getting it, you can develop bleeding, because by removing the components, you may not, the plasma components, you may not be able to replenish them fast enough, so the patients can actually have bleeding complications. In fact, one of the contraindications to doing plasmapheresis is if you did a renal biopsy recently, like in the last 48 hours, you're not supposed to plasma exchange these patients because you can actually cause bleeding. And another serious complication from plasmapheresis is hypocalcemia. And the reason is these blood products, they have a lot of citrate. And citrate actually binds calcium, and the patients can have clinically significant hypocalcemia with EKG abnormalities, and it can even code if you don't pay attention to if you don't follow the ionized calcium. But It's a procedure that is done by a central line. They take the patients, they put the same thing that we do dialysis. It's called a Quinton. You guys know what kind of catheters we use for dialysis? Have you seen a dialysis catheter ever? Mm-hmm. So briefly, there's two types of catheters. One is a tunnel, and the other one is a non-tunnel. The ones that we use in the hospital, like emergency, like this person has Guillain-Barré, we need to plasmapheresis this person. You call the vascular surgeon, and they put the catheter in the typically in the right IJ or the left IJ. Usually the right IJ is easier than the left for anatomical reasons, but this catheter is non-tunnel. I'm sorry. It goes into the IJ, and the tip of the catheter is sitting right above the right atrium. This is for hospital use only. You cannot send the patients out with a non-tunnel catheter because the risk of infection and the risk of bleeding and thrombosis and so on and so forth is too high. So when we're ready to send the patients home, they need to exchange that catheter for a tunnel dialysis catheter. They call it different names. Typically, I'm sure you heard about Permacat. That's one of the names. Another name is a Tessio catheter. It's just the brand. The difference, the technique is different, is that the surgeon, they do this in the OR. They can even exchange it over a guide wire. Like your guys are going to be doing these procedures when you're in the residency, you're going to be put in the central lines. So it's very simple. You just advance the guide wire, you take out the catheter, you put the new tunnel catheter, and then you make a couple of incisions in the chest. You tunnel it, and the reason why you tunnel it is because you want to facilitate, you want to minimize the risk for infection. If it makes a lot of sense. If the catheter is non-tunnel, a simple exit site infection is going to result into bacteremia, right? And possible bacterial endocarditis and all sorts of complications. Whereas if you have a tunnel catheter, the distance that the exit site infection needs to travel is much higher. So these catheters are intended for outpatient use. But the take-home message for you guys to know is that we never send those patients home unless we have a definitive plan. Like definitive plan is like if you're a dialysis patient, you're gonna end up creating a fistula. If you have a limited life expectancy, you're gonna live probably less than 6 or 12 months. That's fine. We leave the catheter. That's actually okay. You don't need to do a fistula for those patients. They're usually very sick and they're not gonna tolerate the surgical risk. But the bottom line is that these catheters, either if they're non-tunnel, is for the hospital stay. And if they've been there like for 2 or 3 weeks, you need to take it out and put it in another location. And if they're going to go home, they need to go with a tunnel catheter. But the teaching point is that those catheters cannot stay there forever. They're associated with complications. Okay, so, and then we know that on your boards, they're going to ask you to answer steroids. The steroids are useless in Guillain-Barré syndrome. So always remember that if the answer to your question is plasma exchange. That's basically how you treat this condition. Okay, very good. So these are different types of weakness that you may encounter in your boards. So you got the Guillain-Barré, which is associated with it's like an autoimmune distal polyneuropathy. It's a demyelinating lesion, and typically they will give you a history like acute after a viral infection. It worsens probably after 2 to 4 weeks, and then plateaus, and then most patients actually they start getting better. Proximal limbs first, absent reflexes, and actually it can also involve the sensory. So you guys are going to get a copy of this PowerPoint. I think Ramiro, did he send it to you guys or not? Okay. Yeah. Okay. So whereas myasthenia gravis, I'm sure you've heard about myasthenia gravis. I'm going to share something that happened to me when I was moonlighting once in the urgent care. There was a patient with myasthenia gravis, and she presented with a UTI, typical UTI, like a lot of like lower urinary tract symptoms, a lot of cells. So I treated with Cipro, and the lady actually returned to the hospital with exacerbation of her myasthenia gravis. She filed a complaint. Actually, fortunately, I didn't get named or didn't get sued or any of those things. But the reason why it was actually very educational, because after this incident, we got an educational session, and the neurologist educated us. Most of the internists, actually, I asked the chief of internal medicine, he didn't even know that fluoroquinolones are contraindicated in myasthenia gravis. Not only fluoroquinolones, but we have many drugs, including macrolides, including statins, they can actually exacerbate the muscular weakness. But typically, the myasthenia patient is more like chronic and progressive. They wake up fine and they start getting tired and tired, during the day, and probably they're more symptomatic at night. And typically, these patients complain of oculomotor symptoms like diplopia or any type of visual complaint, but they have normal reflexes, and the sensorial aspect is not compromised. So those are like the key differences between these two conditions. If you get a question like this on your boards. Okay, so I'm sure you've heard about ALS, right? Lou Gehrig's. You guys know what's called Lou Gehrig syndrome? I'm sorry.
Why is it called Lou
Yeah.
Gehrig? Because Lou Gehrig had contracted it.
Yeah. So it's a very ominous disease. One of my attendings actually had it. And he was so compromised that there was a point that he decided to turn off the vent. And he was cognitively fine, but he couldn't speak anymore. He was completely dependent on other people. And he set a date, and he said on Friday, October, I'm going to turn off the vent at 9 a.m. And that's how he did it. And that's how he passed. But the other syndrome that you may encounter is a paraneoplastic syndrome. It's called the Lambert-Eaton. It's actually a chronic weakness, but typically, as opposed to myasthenia gravis, these patients, they get better with exercise. And it's also an autoimmune antibody against the neuromuscular junction. And the difference is that for whatever reason, these patients get better with exercise. So if you see that on your board question, you're dealing with Lambert-Eaton. Okay, why don't you help me read that second question, please?
HPI, 54-year-old female with worsening shortness of breath and inability to swallow times 2 days, has had fatigue, difficulty keeping eyelids open, intermittent dental vision times 1 month. Physical exam shows bilateral ptosis, mild proximal weakness, and normal reflex.
What do you think she has? Right, sounds like the typical ocular, proximal weakness, mild proximal weakness, and normal reflexes. Okay, so this is question 2. If you can please help me read this question.
A 71-year-old man presents to the emergency department at the instruction of the primary care physician. The patient felt well when he went to bed at midnight, but awoke at 8 a.m. with left upward showing weakness and numbness. He called his physician, who told him to go to the emergency department. He arrived at the emergency department at 9 a.m. The patient's medical history includes hypertension and hyperlipidemia, for which he takes a thiazide diuretic and statin. Blood pressure is 178/92. Physical exam reveals mild left-sided neglect and mild left central facial palsy and mild left upper and lower extremity weakness and a mild left hemisensory deficit. Complete blood count and serum electrolytes and glucose are normal. CT of the brain is normal.
Which of the following is the most appropriate next step in the management? What do you think is going on with your patient? Sounds like a stroke, right? Are you ischemic or hemorrhagic? Ischemic, right? And that's the reason why we do a CT in the first place. And that's the reason why I emphasize, like, the symptoms started at 8 a.m. and then he arrived to the emergency department at 9 a.m. Do you know why this is important? That we establish a very, very accurate timeline when you're interviewing a patient with acute neurological symptoms?
Because the time,
TPA.
Right.
Within 3 hours. So, and we do that just because that's one of the contraindications for TPA is the hemorrhagic stroke. So, if it's an adult, I don't know what they do in children, to be honest. I've never had that scenario of a kid having a stroke, but they can certainly have it related to a small vessel vasculitis or some sort of like vascular malformation or other things. But it's a clinical diagnosis, right? And you do a CT. And if patients present within 3 hours, there's no evidence of intracranial hemorrhage, you go ahead and you do it. Have you guys ever seen how they do it in a hospital? So it's actually very dramatic. It's like when Dr. Ben-Zur gets a case, like MI. Like time is tissue, time is outcome. So they activate most hospitals that are like a star center for treating strokes. They activate a co-stroke and they immediately put a stroke attending on the phone. It's not just a neurologist, it's a neurologist that subspecializes in stroke management, and they have to try to reconstruct the sequence of events. They have to consent the family, and usually If it's usually one of us, like if I'm on call, the internal medicine doctor, you have to consent the family for the use of TPA. And you guys know TPA is not a benign drug, but it can really save brain tissue, and it can really change the outcome. So you need to establish a consent where you tell them they can have a hemorrhagic transformation, they can have bleeding, they can actually even die. But it's very. I've only done it once, and it was very stressful for the family to make that decision. But you're talking about like by the time you get the CT, you need to start getting on the phone with this person back and forth. So there's a lot of drama during that sequence of events, but it works pretty well. It works pretty nicely, and the patients actually usually have most patients have a good neurological outcome. If your patients are having rapidly improving symptoms, that means that we're probably dealing with a TIA, and we don't manage TIAs with TPA. Or if the patient is severely hypertensive, that's usually a relative contraindication. And I'm saying relative because ultimately the decision of doing it or not depends on the neuro attending. Not even us, internal medicine. It's usually the neuro attending that makes that decision. But typically, what we do in the emergency room is that the patient is having symptoms. You do the head CT. The head CT is negative. Immediately you give him an aspirin to reduce the rate of recurrent stroke. And immediately you put them on like subcutaneous heparin to prevent the DVT. You're admitting the patient. You do airway protection, and these patients, you don't feed them until you do a swallow evaluation. Have you guys seen a swallow evaluation? Have you guys seen how it's done? So it's usually you put a consult for a speech therapy, and they go in at the bedside. They have them swallow. They can do it either by observation, or they can take the patients to the speech lab, and they can actually do a fluoroscopy, direct observation in how they're swallowing. But most swallow evaluation is a bedside observation, and just by the first sip, they know already whether or not there's a problem. And blood pressure, you may get tested on this because in acute strokes, we still do something that's called permissive hypertension, meaning that you do not want to drop the blood pressure acutely unless you're dealing with dissection. I'm gonna tell you the exclusions in a minute. But if the patient is just like presented in the 180, 190, for the first 48 hours we allow them to be hypertensive, because the studies show that increased perfusion, that increased pressure, is associated with increased perfusion of the brain tissue, and that's what the evidence showed, that it's better to leave them run hypertensive a little bit for the first 24, 48 hours. And hypothermia, you're going to hear a lot about hypothermia. Therapeutic induction of hypothermia is currently a standard of care in the United States after you get like a PIA arrest, and the patient actually immediately you try to if you have a cold blue, immediately after the cold blue, the patients, if you're able to reestablish the return of a spontaneous circulation, you put the patient on a hypothermia protocol, because that's associated with better neurological outcomes. But as of now, we don't have data supporting that patients after a stroke they should be hypothermic, and these patients are usually sedated. I mean, you can even imagine like you're going to be able to tolerate like this kind of because the body temperature is brought down to, if I'm not mistaken, it's 32 or 31 degrees Celsius, so it's pretty low. And you make sure that these patients are normal glycemic. So again, we don't treat hypertension unless the patient is like crazy systolic blood pressure of 220, or these are the scenarios like if a patient is having a concomitant heart attack, aortic dissection, or if they have a hemorrhagic conversion of the stroke, yes, those patients we bring them down. But if they don't have any of the three that I mentioned, you let them run a little hypertensive for the first 48 hours. The agents of choice is nicardipine. It's a calcium channel blocker. This medicine is used very commonly when there's a hemorrhagic conversion, because it's thought to reduce the calcium channel blocker is thought to reduce the area of the hemorrhagic stroke. So that's actually the drug of choice. But we also use labetalol. If you get a question about aortic dissection on your boards, IV labetalol is the correct answer. That's how we manage And nitroprusside is the other drip that we use very commonly when they're severely hypertensive. Okay, why don't you help me, Jonathan, read the three.
An 82-year-old woman living in a nursing home is evaluated for an impairment of gait and balance. She first had difficulty walking and recurrent fall 6 months ago and now requires a walker. She has diabetes mellitus and gastroparesis, hypertension, and depression. Her current medications include glyburide, an ACE inhibitor, lansoprazole, metoclopramide, and fluoxetine. On physical exam, she has decreased facial expression in the hypophonic speech.
Hypophonic.
Hypophonic speech. Mild to moderate rigidity and bradykinesia bilaterally, difficulty standing up, shuffling gait, and occasional freezing and impaired postural reflexes. What is the most appropriate next step in management of this patient?
What do you think she has?
Parkinson's.
So what do you want to do for her?
Doesn't metoclopramide cause?
Yeah, absolutely. Metoclopramide should never be used for more than 3 months continuously on anyone, because most patients, they end up developing this picture. I mean, in different degrees of involvement, but sooner or later everybody's going to end up developing this Parkinsonian. So drug-induced Parkinsonians is going to be on your boards. Just remember the associated agents, usually antiemetics, metoclopramide, antipsychotics, Haldol, or any of the typical, less likely atypical antipsychotics, but they can all cause it. And I was surprised to learn that calcium channel blockers can cause it, but I've never seen a patient with Parkinsonism associated with calcium channel blockers. Typically, it's reversible after removing the offending agent, but some patients, they may have symptoms permanently if you use them, especially like psychiatric patients. When you see psychiatric patients, they may have like these dystonic movements from the use of these medicines for a long time. But when it comes to the Parkinsonians, when it's not related to a drug, you think about the neurodegenerative processes. Probably the most common ones are the progressive supranuclear palsy, multiple system atrophy, corticovasal degeneration, and Huntington's disease. You guys know about Huntington? It's autosomal dominant. Actually, my sister-in-law's mother died from Huntington's, and she never wanted to be tested. And my brother basically respected her decision, but it's a tough thing that you need to live with. These diseases all can present with early Parkinsonian features, but the classic Parkinson's syndrome is, these are other diseases, sorry. The essential tremor, this is the one that's pretty common. You're going to see elderly patients with this. And this is the one that usually gets better with beta blockers and with a little bit of alcohol. And you ask them if when you drink wine you get better. And if they do get better, that's usually essential tremor. And it's a pretty benign neurological condition. It's something that doesn't necessarily need to be treated. Or you can give them a little bit of a beta blocker. Restless leg syndrome. Have you guys heard about restless legs? Okay, it's pretty annoying and it's associated with what disease that we talked about 2 days ago? Which disease is associated with restless legs? We talk about it. Sleep apnea. Yeah. So, and they usually use. It's another condition that can be diagnosed in the polysomnography lab when you do a sleep study. So the focal generalized dystonias. These are either cervical dystonia. These are patients with some sort of like repetitive cervical movements. Blepharospasms. You guys know how we treat blepharospasm, or how the neurologist treats blepharospasm? Botox, yeah. It's actually very effective. One of my dialysis patients has it, and then he no longer has it. But it lasts about a few months, and then it wears off, and then they have to get more injections. Oromandibular dystonia and spasmodic dysphonia. These are all like isolated conditions. And lastly, the one that you're probably going to get tested on your boards is the idiopathic Parkinson's disease. The patients typically have a resting tremor. They have the cogwheel rigidity, bradykinesia, postural instability. A very interesting feature about these patients is that they have a severe autonomic dysfunction. So one of the early manifestations can be severe orthostatic hypotension. There's a associated condition called Shy-Drager syndrome. Have you guys heard about that syndrome? It's a variant of Parkinson that is associated with more severe autonomic dysfunction. These patients can actually have like recurrent syncope, unexplained syncope, and is related to the body's inability to maintain normal blood pressure when you stand up. The treatments that are associated, we have many new treatments. I'm sure you heard about like brain pacemakers and some sort of like a stimulation, deep brain stimulation. That's actually the new standard to manage these patients. But most of the times we treat them with levodopa and carbidopa. Levodopa, what else is it used for? You guys remember? Carbidopa? You guys remember what other scenario we use carbidopa or levodopa? It actually stimulates insulin secretion by the beta cells. So some physicians use it for diabetes management, but it's not commonly used for that. We have the amantadine, the anticholinergic for younger patients. Do you guys know why we wouldn't use anticholinergics in the elderly? Why are those bad drugs for the elderly?
They're already dried out.
And what else?
Why you want to dry
Dementia,
them out?
delirium.
What else do they cause?
Altered level of consciousness.
What else? So if you're an old patient, like have an old person say, oh, I want to take Benadryl, or I want to take amitriptyline, any medication with
What is that, like the alpha-lipopathy? Orthostatic hypotension, is that?
it can cause urinary retention. So anticholinergics primarily alter mental status, confusion, and inability to urinate. So we don't use those medications in the elderly. And MAO inhibitors. On your boards, you may get a question about somebody that was taking one of these monoamino oxidase inhibitors, and they had wine or they had cheese, and they developed severe hypertension. Have you guys gotten that question yet?
Yeah.
So, if you prescribe a monoamino oxidase inhibitor, you have to educate the patients extensively. That's one of the black box warnings for prescribers. I have never prescribed any of these medications because they're very specific to the field of psychiatry. Nobody else uses it, and neurology. All right, so normal pressure hydrocephalus. Okay, so normal pressure hydrocephalus, guarantee you're going to have that on your boards. So typically they give you an old person, and that is actually getting decline in the cognition, gait impairment, and urinary incontinence. If you have that triad, that's a classic triad for normal pressure hydrocephalus, you pretty much have the diagnosis. You're gonna have the question correct. So dementias, we have many different types of dementias. Most of the times is a clinical diagnosis. Now they're using more and more the imaging as part of the criteria for diagnosis. I'm sure you heard about the frontotemporal dementia. These patients actually they present with one of the early signs is changes in personality, but they have a impaired executive function with a preserved visual spatial function, and this is an important distinction because when you have a patient with Alzheimer's, you have them do the clock test, or have you guys seen a mini mental test? How it's done? Okay, so some of the components include like drawing, and the Alzheimer's disease patients they have a very hard time with the visual spatial function, whereas the frontotemporal dementia they have more like gait, executive function, like motor involvement. Whereas the Alzheimer's is more visual spatial early enough in the course. Later they have more, obviously they have motor involvement as well. The Lewy body dementia, these patients they present with hallucinations, fluctuating cognition, and Parkinsonian features. All right, why don't you help me read this question, please?
27-year-old man.
Oh, I'm sorry.
A 27-year-old man comes to the office for advice about treatment of his recently diagnosed Sclerosis. 3 years ago, he had an episode of hypoxia that resolved entirely after 2 months. 1 month ago, he had mild weakness and numbness of the right leg. MRI of the brain at the time showed multiple cerebral simple white matter lesion in a pair with circular distribution plastic and multiple sclerosis. His leg weakness resolved without treatment. He is now asymptomatic and has a normal neurological exam.
Which of the following is the most appropriate treatment? So he has multiple sclerosis. How do you want to treat this person? Interferon? Okay, he's had several relapses, so probably yes. Patients that only present for the first time, the disease actually may go away, but this person seems like he's having recurrent symptoms and has MRI evidence of the white matter lesions that are distinctive for multiple sclerosis. So on your boards, you're gonna get typically patients that present with optic neuritis, especially a young female. It's a multiple sclerosis suspect until proven otherwise. That may be one of the first manifestations of this disease. They can present with pretty bizarre complaints, hemiparesis, hemisensorial disturbances, like a band-like distribution around the trunk. They can even present with a neurogenic bladder or with cognitive decline. The treatment usually you do in the acute exacerbation, you treat them with the steroids. Most of the times you need to admit these patients to give them solumedrol. Typically we do like anywhere from 3 to 6 milligrams per kilogram of solumedrol when we admit them. And you start doing a prednisone taper over the next few months. And right now we have more and more medications, not necessarily the interferon, but there are other monoclonal antibodies that are FDA approved for the management of this disease. And I don't know, have you seen patients with this? Have you seen? Is she functional or she's?
More.
Has she progressed or?
Yeah.
So.
She got it at 35. She's 60, and she's bedbound.
I'm sorry to hear that. Yeah. So some patients can actually have a very light course, like 1 or 2 flares, and they have a normal life. But some patients, no matter what, they have a progressive course, and it's challenging disease. Typically, on your boards, they may give you a patient that already has an established diagnosis, and one of the precipitating factors is a urinary tract infection. So we treat aggressively these patients when they suspect that they are having a urinary tract infection because we know that that's a very common exacerbating factor. Which other conditions do we treat asymptomatic bacteriuria?
Pregnancy.
In pregnancy, pretty much. Even in transplant recipients, we try to stay away from treating them unless they're having symptoms. But pregnancy, and this is probably another scenario. Now, these patients we wanna have an aseptic urine just to prevent the relapses. Okay, can you help me please with this question?
A 28-year-old woman evaluated with daily headaches for which she takes non-steroidal anti-inflammatory agents or phenylphenidal aspirin heparin daily. The headaches have improved for the past 6 months, and she has had other headaches since age 16 years. She recently changed jobs, and although she enjoys her work, she does not enjoy switching shifts every 2 weeks. She no longer sleeps well and feels like she needs to control her life. Her headaches previously were described as throbbing unilateral pains associated with nausea, lasting 6 to 8 hours with a frequency of twice per month, but they are now daily low-intensity pains associated with mild constant nausea or anorexia. Headaches escalate to a severe intensity about 2 to 3 times a month, requiring injectable medications for relief. Physical exam shows only mild obesity.
Okay, so what do you think is the most likely diagnosis? Pseudotumor? Medication overuse probably, right? So this is pretty common in clinical practice, but let's talk about the different types of headaches. So the migraines, typically the patients have a throbbing pain with photophobia and phonophobia. If they have brainstem involvement, they can actually have like the typical aura symptoms, the nausea, pallor, flushing, tearing, rhinorrhea, and sinus congestion. A lot of the patients, 70% of the patients can actually have like they know that they're going to have a migraine like hours before the onset of the crisis, and up to 25% they have the symptoms right before the headache starts. The treatment, if you want to memorize something from today's talk, you never treat migraine with narcotics. Never. Why? Because they're ineffective. Do you guys know what the FDA approval of narcotics is? What is the label indication for narcotics? Do you guys know? When do you prescribe narcotics?
In cancer patients?
In cancer patients, like advanced management of advanced cancer patient, and acute pain. And but you don't treat it. You don't treat acute, like post-operative pain. Probably that's when we use it. But we don't treat chronic conditions like migraines or daily chronic headaches with narcotics, or fibromyalgia. You never treat with narcotics because it's the worst therapeutic choice of all. But the triptans are usually very effective. We have many different formulations available. They're contraindicated if you have coronary disease because they can cause coronary vasospasm. So that's probably the only contraindication. If you have advanced kidney disease, you need to renally dose it, but the rest of the scenarios you can use it. Rescue medications, when they go to the urgent care, you can basically give them different things. But opiates, try to stay away as long as you can, because once you start treating these patients, chronic patients, with opiates, they're going to keep coming to the urgent care for the same thing over and over. So it's usually either there's no other way you can use anything. Like you have a patient with advanced kidney disease, you can give in an NSAID. You have a patient with coronary disease, you cannot give in a triptan. Then you're kind of stuck. And you want to help the patient maybe, but it's actually the worst therapeutic choice. Clusters. How to distinguish? Basically, have you guys heard about the clusters? Cluster headaches are pretty dramatic, and they can cause actually disability. You can't even function when you have. But the migraine cluster versus the tension, typically the tension is like, is the person telling you is like occipital. It's associated with muscle, posterior neck, and shoulders rigidity and pain. Whereas the migraine is typical, the throbbing, more like unilateral, like the classic preconditioning symptoms. Another way, to distinguish the migraine versus the cluster, is that the onset is very gradual. You start like building up over time, whereas the cluster can actually be very, very sudden onset and very severe. And the migraine can last hours to days, whereas the cluster, it happens very quickly and it resolves very quickly. But I'm pretty sure like someone with this kind of pain, like for 3 hours, nothing is quick. But this is another way of distinguishing. You want to ask, when you're getting a history from your patient, you want to ask about the onset. Was it gradual or was it very sudden? You want to establish duration. You want to establish location, and always you want to establish medication habits, because the more you use medications, the more your body becomes dependent on them. And there's this I wouldn't say new, but it's been probably described in the last 10 years. And it's more and more recognized in clinical practice that chronic daily headaches, it's a significant clinical problem. And you guys know how we treat chronic daily headaches? I'm sorry? You might, but the mainstay is to get them to stop all pain medications. Imagine how hard that is. So, because most patients are not going to be able to come off the medications. They're going to just keep taking them. All right, please help me with the question number 6.
80-year-old man with mild cognitive impairment is evaluated for dizziness and unsteadiness and began after he started phenytoin therapy. 3 days ago, he had a second generalized tonic-clonic seizure in 3 months and was treated in the emergency department with intravenous phenytoin. He was prescribed daily oral phenytoin on discharge. His only other medication, warfarin, prescribed after heart valve surgery 8 months ago. The patient's phenytoin level at this time is within therapeutic range. MRI of the head and electroencephalogram are normal. What is the best treatment option for this patient's seizure disorder?
What do you want to do? Continue on?
Is there a contraindication between using phenytoin with the other one?
With warfarin, yeah.
Or warfarin with that?
Yeah. By cytochrome P450, yeah. Yeah.
So you gotta stop the phenitone.
Yeah, you have to switch to something else. This guy probably had a stroke because by the INR level is probably under therapeutic in this person, and it's a problem in clinical practice when you prescribe any medication in someone that's taking Coumadin. You have to make sure to know what you're doing. In the hospital setting, we usually call pharmacy. In the outpatient setting, depends who manages the Coumadin. The person that does Coumadin adjustments, they know very well that a lot of medications can actually affect the level, the range of the INR. But both phenytoin and carbamazepine can actually cause cytochrome P450 induction, and you can definitely have very low levels of INR. The other consideration in clinical practice is that if you have patients with transplants and you prescribe these medicines, the same thing can happen. Actually, the levels can become undetectable, and that's why every time you add this medication, phenytoin is huge for interaction. So I want you guys to take that message. Like, phenytoin needs to be prescribed by somebody that knows what you're doing, and it's not just following the phenytoin level. It's make sure that there is no other interactions with the other medications. So why don't you help me, Kristen?
A 45-year-old man is evaluated in the emergency department for convulsive status epilepticus. A passerby found him having a seizure on the sidewalk, and paramedics were on the scene within 5 minutes, bringing him to the emergency department in about 10 minutes. His medical history is not known. There are no external signs of trauma. A fingerstick glucose measurement taken by the paramedics was 90 milligrams per deciliter. Serum is obtained for measurement of glucose and electrolytes in a toxicology screen. What is the most appropriate initial intervention for the patient?
Yeah, absolutely. You're not going to send him for a CT if he's still on status. And phenytoin, you load them, but it's not as effective or as quick as lorazepam. And phenobarbital it can be prescribed as a coadjuvant, but it's usually Ativan IV. So you call it epilepsy when you have 2 or more unprovoked seizures. We know that most patients with epilepsy, they have actually normal brain anatomy, but some patients can actually have the seizures from some sort of focal abnormality, and that's one of the reasons why patients with seizures, they always have to have a brain imaging just to rule out a malignancy. It can be either a vascular malformation, tumor, restricted scar, or some sort of abnormal development of the brain tissue focally, causing epileptoid foci, explaining the recurrent nature of the disease. Typically, you don't start treatment right away if there's no major structural abnormalities of the brain. But typically, make sure you document very carefully that the patients they were instructed not to drive, and you need to report them to the DMV. It doesn't just stop there by you telling them don't drive. You need to send a form, because if there is an accident, you're going to be liable for not reporting them. The risk, and you need to tell the patient, because there's nothing that will piss off more a patient than actually reporting them without telling them. So it sounds like, it's mandated that you need to have a clearance by one of the DMV physicians, and I'm mandated to report you because you shouldn't be driving for the next 6 months. So emergency room doctors, they're very careful about that. Go ahead.
Do you do imaging after the first seizure?
Yeah, you should. I mean, I know in kids they probably don't do it because of the risk of radiation and everything, but if you have an adult, you may be dealing with a new onset structural abnormality. So nowadays, they have such a low threshold to doing this kind of imaging that probably everybody gets it. If you have a first episode, your risk of recurrence is 30 to 60%. If you have a second seizure, your risk of recurrence is 80 to 90%. So, and the other thing that you should tell the patient is that they cannot work in roofs, they cannot do scuba diving, or any type of activity that requires attention. And because it happens, right? So medication depends on the type of seizure that you have. The absence is the typical. They may give you a young kid that's spacing out in school that have no idea what happens, and when they do the EEG, they're able to pick up the abnormality. So these patients are treated with ethosuximide, but most patients with generalized tonicclonic, Seizures are treated either with phenytoin, carbamazepine, phenobarbital, and valproic acid. All of these medications require labs. Phenobarbital can cause, over time, it can cause cognitive impairment. It can cause physical and psychological dependence. It can cause gum hyperplasia. It's a medicine that we don't use it that often, but you will see patients taking this medication for a long time. You cannot stop it abruptly because you can actually have seizures from withdrawing phenobarbital abruptly. The partial seizures are usually very responsive to. Now we have a medication called Keppra. Have you guys heard about Keppra? So Keppra is very effective, and it's the nice thing about Keppra is that the interaction profile is a lot more benign than the interaction profile from the others. And when it comes to pregnancy, most of these medications are category X in pregnancy. You need to definitely consent these patients, and if they're in reproductive age, you need to document that you have a plan for contraception. Some doctors won't even prescribe it unless they know the patient's already on contraception. But Keppra still can be teratogenic, but it's the one that they're using nowadays when the patients are pregnant. Lamictal is one of the newer agents. Topamax. Have you guys seen anybody on Topamax? You guys know what else do we use Topamax for? Weight loss. Very good. And migraine prophylaxis. So, and yeah, and yeah. So, but more and more people are using these medications, and it comes in combinations with amphetamine and Topamax, like a suppression of your appetite from two angles, different two active medications. So, and if you have cognitive impairment, most of these patients, they end up on phenobarbital. Okay, so if you have encountered someone with Statusepilepticus, you do the ABCs, including the need for intubation, Ativan, 0.1 milligram per kilogram, and then you do a phenytoin load. You usually put 3 amps, and I think each amp is about 50 milligrams. You put 3 amps in 500 of saline, and you run it over an hour or two. That's how you phenytoin load the patient. And the other options are pentobarbital or phenobarbital. All right.